natural history. He's got it, as you see. This is what we call a successful treatment. Change of natural history. So instead of 50%, now we have 100%. So this is something heroic, and as you say, adult deformity especially is as difficult as this. It's not as difficult. So consider I can do it. I cannot outrun a cheetah, but then again, it's fairly difficult, I should say. Why is it different? We're a very heterogeneous population. We are all adults, so if we have deformity, we're going to be categorized as adult deformity. Our parents are adults as well. So if they have deformities, they're going to be categorized. And I'm assuming that at least for some of us, our grandparents are alive and they're adults as well. So if they have deformity, their deformity is going to be classified as adult deformity as well. So it is a huge range, and it can be ascending scoliosis, the artifact of a descending scoliosis, or a de novo descending scoliosis as well. But what is an important consideration here is that adults, especially as they age, do not consider cosmesis as a very important factor in their lives, whereas functioning becomes much more important. If you ask a 13-year-old girl, she would rather look good than be able to walk 100 meters. Or on the contrary, if you ask a 80-year-old woman, she would accept looking terrible so as to be able to walk 100 meters. So their perceptions of their deformity, perceptions of the problem are actually very, 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 very different. So this is one adult deformity. This is a manual worker, 38-year-old male. As you can see, he is deformed. He has scoliosis, as you can see here. He has kyphosis here in his lumbar spine, an area that should have been lordotic. And this lady, 72 years of age, is actually, this is adult deformity as well. As you can see, there is scoliosis. And as you can see, he is probably 15 to 20 centimeters forward. So she is like this. I can tell you, she can only walk 50 meters. And if we do not treat this lady, this deformity is not the only problem here. She has spinal stenosis as well. If we do not treat this lady, she's probably not going to be able to use the toilet in her house in some years. It may be 3 years, it may be 5 years, but it eventually happens. So this is like adolescent idiopathic scoliosis was cosmetic surgery. Here, now we're not doing cosmetic surgery. This is essential surgery for the elderly population. We did not recognize this 20 years ago because our elderly population was very small, especially in Turkey. We had a very small elderly population. But now, as our population ages, as your population ages, this becomes a real problem. And interestingly, I am a part of a study group. This is called European Spine Study Group. So this is like a piggyback. We just put all our adult deformity cases in this bag and then just evaluate these. So this is something done on 400 adolescent idiopathic scoliosis cases. These are the tests for function. You may or may not know them, but these are the objective criteria to test whether a patient is functional or not. And as you can see here, lumbar lordosis, or these are called sagittal balance parameters, have very high correlation with the function of the patient. So as the patient, as we age, as we fall forward, we are actually losing function. And we should not, by definition, let these patients fall further forward. So if the patient is balanced, if they are balanced, they can tolerate up to 50, 60 degrees of scoliosis. But once they actually fall forward more than 5 centimeters, they tend to just succumb and fall forward every year more and more. This is what we want to correct. I'll just show you a couple of cases about what can be done. This is a 67-year-old lady, fairly osteoporotic, fairly good posture about spinal stenosis. This is what we have done. Now, this is at 2 years. This is, as you can see, a more severe deformity. This is a lady, very similar to the lady that we were seeing. And this is what we had done, early postoperative, 1 year follow-up. And this is a 61-year-old lady with osteoporotic fractures. This was done at St. Elsewhere Hospital. As you can see, kyphoplasty, percutaneous fixation, but she's still falling forward. So this is what we've done to this lady. As you see, as the deformity gets more and more serious, I don't know whether you're noticing this, but the surgery is getting more and more serious as well. If you just look at the rods and the screws, they're the same rods and the screws. But I can tell you here that as you can see, this is a cage here. This is a cage here, and we did not do anterior surgery for this lady. So this is a 2-level posterior osteotomy. Now, this 78-year-old lady was in surgery for about probably 8 hours or so, and she bled about 3,000 cc's, 3 liters of blood loss. So there is no limit to their functional incapacities. They can be functionally very limited, but they can be very difficult to treat as well. So as I'm telling you that we have to treat these patients, I'm not telling you that it is easy. It requires fairly high technology hospitals, fairly highly knowledgeable support personnel, and fairly accustomed surgeons as well. So this is why I've shown you the cheetah. Okay, so this is before, and this is after 2 years. But this took, as I said, 3 liters of blood loss and an 8-hour operation. In summary, adult spinal deformity is not similar to pediatric deformity. Restoration of function is the ultimate goal, and by function we have to understand, it's easier to understand, sagittal balance. These patients lose their function when they lose their sagittal balance, and restoration of the sagittal balance takes longer instrumentations and often spinal osteotomies. I'll just show you 3 slides of TV spondylitis because it's probably something that you see. We do surgery on TV spondylitis in Turkey. It's fairly common in Turkey as well. It was more common 20 years ago than it tended to disappear about 10 years ago. Now we're starting to see more and more patients again in the last 3 to 5 years. The indications for surgery are neurological involvement, deformity or impending deformity, and presence of large abscess. The first one is fairly understandable. The second one, impending deformity, means there is a very simple rule to this. If you have the destruction of one complete vertebral body, it comes to you as 30 degrees of kyphosis. So if you have lost 2 vertebral bodies, it comes to you as 60 degrees of kyphosis. 3 comes to you as 90 degrees of kyphosis. So we do not wait for them to develop 90 degrees of kyphosis before operating on them. When we look at their MRIs, when we look at their x-rays, if we see the destruction of 1 to 2 to 3 complete vertebral bodies, then we tend to operate on them earlier. Because it's easier to operate on them earlier, it's easier to correct their deformities if you detect the deformity before the deformity actually happens. And then thirdly, the presence of a large abscess or necrotic tissue. We have a series of over 100 patients that I have compiled when I was a resident. Of these, 54 had large abscesses. Of these, 16 have drained by themselves. So they develop fistulas. So those large abscesses actually are not amenable for treatments with chemotherapy only. You have to drain them. You can drain them with open surgery. You can drain them with percutaneous surgery. It's up to you. And it's up to what is available in your center. But you have to drain them. So 2 cases. This is a Thoracic one, fairly familiar, as you can see, abscess on both sides, some abscess on the epidural space as well. The gold standard for treatment for us now, and I am in the team with a fairly large number of publications on this. If there is destruction of bone or if there is abscess in the anterior column, we tend to treat them in the anterior column. So our gold standard now is anterior instrumentation and fusion. You can use anterior instrumentation, you can use anterior bone, you can use anterior cages, you can use whatever you want anteriorly, but it is anterior instrumentation. And this is another case, again, as you see, this patient we saw with paralysis, huge abscess on one side. And as you can see, anterior instrumentation and with an anterior cage as well. So in summary, deformity surgery is one of the last frontiers in spinal surgery. We are all successful, but it depends on good patient selection, good planning, having adequate resources. This is mandatory. You have to know what you're going to do. You have to be sure that you have those resources to do this. Knowing the spectrum of possibilities and being aware of your abilities and shortcomings. I can do this, I cannot do this. There are things that I cannot do, there are things that I can do. So I do not do the things that I can do. And it does not depend on the type of instrumentation. So do not think in terms of what instrumentation I use, what instrumentation I have, what instrumentation I do not have. It's based on basically your abilities, not the instrumentation. The instrumentation does not correct the deformity. You're going to be the one to correct the deformity. Thank you.